Hello, welcome everyone. We'll just get started in just a minute as we wait for people to file on in from the waiting room. Thank you so much for joining us today. All right, thank you everybody for joining us. Just a few housekeeping items before we get started here. The chat function is disabled for today's webinar, but please feel free to go ahead and use the Q&A button at the bottom of your screen or in your the side if you're on a phone. We had our questions pre-submitted for this webinar. Thank you so much for everyone who sent in questions. But go ahead if you have other questions to enter them into that Q&A and we will get back to you afterwards. This webinar is being recorded today and will be available on YouTube afterwards at youtube.com/solvecfs. And lastly, you can enable captions if you want those. You can do that by hitting the transcript or the CC button at the bottom of your screen or in the settings if you're on phone. And thank you so much for being with us today. And I will hand it off to Oved Amitay.
Thank you very much, Jesse, and thank you all for joining us today. I think it's fair to say that many members of our ME/CFS community were probably among the first to be concerned about the risk of SARS-CoV-2, that it could trigger post-infection syndrome that include ME/CFS, postural orthostatic tachycardia syndrome, or POTS, mast cell activation, just to name some. And a year and a half later, we're very sad to see that we were actually correct. And the number of people that are affected by long COVID or PASC, as we call it, is so alarming that some experts are now saying that this is going to be the next public health crisis. As a community, we felt compelled to be involved from the very beginning. First of all, really to embrace the people who are affected by long COVID so that they don't have to suffer alone as many of us have. But also to share existing knowledge that our community has, meaning patients, clinicians, researchers, and really share that with people who are now facing long COVID. So that was something that we felt very important to do, and also with the belief that progress in understanding and treating long COVID will provide benefit for people with existing disease. Our organization, SOL, was very involved with many others in calling upon Congress to fund this effort to study long COVID, and we were thrilled when at the end of last year, $1.15 billion were appropriated by Congress to the NIH to specifically study long COVID. And as of course we were hoping to see, the NIH recently announced the launch of this study that is called RECOVER. And so we're very, very eager to hear more and learn more about the study, and in particular how it is potentially connected to ME/CFS and other post-infection diseases. So we couldn't think of anyone better to do that than Dr. Koroshetz, who really has been an incredibly important supporter of the ME/CFS community in the past. I may not need to introduce you, Dr. Koroshetz, to this group, but in case Sure. There are some other people who don't know you, I will obviously say that Dr. Koroshetz is the director of the National Institute of Neurological Disorders and Stroke, one of the most critical institutions within the NIH. It is part of the larger umbrella of the National Institute of Health. And the mission of the NINDS is to seek fundamental knowledge about the brain, nervous system, and to use this knowledge to reduce the burden of neurological diseases. And of course, ME/CFS is one of them. So, Dr. Koroshetz, we're really very, very pleased that you could join us today. And I think you will share with us information that perhaps will be shared publicly for the first time about how the Recover effort is now unfolding. And we're really looking forward to your presentation. And thank you for your willingness to address questions after your presentation. Thank you very much.
Thank you, Oved. It's my pleasure. And I'm just going to bring my slides up in a second. And I'm guessing that you can see them okay? Okay. Well, yes, as I said, it's a pleasure to talk to you today. Whoops. Oh, sorry. This looks like the last slide, not the first slide. And as Oved said, as the director of the NINDS and also the chair of the Trans NIH ME/CFS working group, we also got very worried early on that one of the long-term consequences of this terrible epidemic could be a large number of people who develop ME/CFS after COVID. And as Oved said, that's what's happening now. And unfortunately, we still don't know enough to prevent this from happening. But I think due to the work of Solve ME and other groups, Congress became interested last summer. We had a couple of meetings with different congressional groups, and then the funding came, in November, December, and we then started planning what is a fairly ambitious, I think incredibly ambitious program to get at the bottom of the problem. And I would say, I have been working in ME/CFS long enough to know that there's unlikely to be a quick fix. And so we're actually putting together a program that I think will be sustainable over the long run. And that's what I want to talk to you about today. But I just wanted to start out by saying that this is a Trans NIH program. All the institutes are involved in this program. I am the co-lead with Dr. Gary Gibbons from the National Heart, Lung, and Blood Institute on the Recover COVID program. We're basically following the mission of NIH, was in this space, to understand the nature of this post-acute persistent symptoms of COVID. And then with that understanding that we get, to try to use that knowledge to reduce the burden of illness due to what some people call long COVID, but long COVID may be only the tip of the iceberg, as we'll potentially mention down the road. I would say that, as the key thing for all of us on this call to know is that the most debilitating symptom in people with long COVID is fatigue. So, of the people who have persistent symptoms, the percent with fatigue, and some of them is like 95, 98%. And of course, that's, a clear problem that we've all been facing with ME/CFS as one of the things in ME/CFS that is disabling. And I just wanted to start out by saying we don't really know a lot about how we as individuals develop that sense of fatigue. We know a lot of things that can cause it, but how those causes then trigger, I think, in our brain somewhere, the sense that that we just can't go to the next level. We can't get out of bed. We can't walk to the store. We're getting some inputs from our body that are telling us this, and we can search for where those inputs are coming. but also important to understand is where in the brain is that information processed. And so we actually had a very interesting workshop just a couple of weeks ago on this topic of, the biology of fatigue, we called it. And so an example of trying to understand some of the basic knowledge about fatigue that I think will be important for both the post-COVID situation, because fatigue is so big, and in ME/CFS. Now, so I would going to talk to you today as COVID as a prototypical example of an infection that can then lead to the symptoms of ME/CFS, and how much this situation transfers to other people with ME/CFS, not entirely clear, but I think there is a high chance that we will learn things from studying this intense study of post-COVID syndromes, and that will help people who are suffering from ME/CFS, particularly those who are suffering, because they had some viral infection in the past. We don't know what it is, but then they developed ME/CFS months, years later, it's diagnosed. So, but in COVID, the thing we know about COVID now is that it affects so many different organs in the body. It gets in through the nose and the nasal passages. It's very difficult to stop the infection from getting there. The vaccines are much better at preventing the infection from getting down into the lung. And that's where most of the mortality is coming from, is from the infection in the lung, which leads to what we call acute respiratory distress syndrome. But there are lots of problems with the GI tract, with the heart. There are clots that form in the heart. There's fibrosis in the heart. And pretty much all the organs of the body can be affected by COVID. And one of the reasons is because COVID enters cells through what's called the angiotensin converting enzyme receptor 2. That receptor is on a whole bunch of different cells all over the body. So any cell with that receptor is vulnerable to being attacked by the virus. Even the brain. Now, the good news is that certain viral infections, the virus gets into the brain, threads through the brain, causes terrible destruction. That does not seem to be the case in COVID. What we've seen so far in the brain is the virus effects on the lining cells of the blood vessels. And that's because they're very rich in this ACE2 receptor. And what that causes in the brain is a breakdown of the barrier between the blood vessels and the brain. So you see here leakage, these green dots are leakage of dye coming out of the brain, out of the blood vessels into the brain. And that then causes inflammation, which is seen here in these cells that these little black dots, which are they're really, shouldn't be here, but they are inflammatory cells that then come in around the blood vessel because of the kind of injury and irritation that this leakage has caused. And that would potentially cause symptoms. So people with COVID, acute COVID, not infrequently are delirious. They can be agitated, confused, very disordered mental state. Many of those people can recover, though, from that state, because it's not a lot of actual damage like you might see in a stroke. Now, there are strokes that occur in COVID as well. There you can see some disastrous outcomes. And sometimes what we see is tiny little strokes in the brain, and that's probably much more common than the really big disastrous strokes that cause long-term damage. Now, if you look at the symptoms of post-COVID, which are here in the different boxes, you can see that they overlap, really pretty amazingly with the symptoms of ME/CFS. So as I said, fatigue in almost 99%. Now, post-exertion malaise, which is a real signature of ME/CFS, not been that well studied. but there is one, patient study which claims it's as high as 90%. So, so if you have fatigue, you have post-exertion malaise, you have sleep disorder, you have post-orthostatic tachycardia, and it goes on for 6 months, that's ME/CFS. So that's what we're seeing, people coming with persistent symptoms, and many of them get better, but unfortunately some of them do plateau, and now they're out past 6 months, which is kind of that arbitrary cut point for ME/CFS. So in my mind, ME/CFS and the post-COVID syndrome are really very overlapping. The hope is that we can understand this one, we can then understand ME/CFS better. But look at all these other things: memory, word finding trouble, concentration difficulty, executive function, sleep disorders, pain syndrome, headache, post-orthostatic tachycardia, dizziness, balance problems. These are all ME/CFS symptoms. These may be a little different. There's evidence of involvement of the chest more so in post-COVID, with chest pain, cough, shortness of breath. That's probably more prominent in the post-COVID cases. Exercise intolerance, of course, is across the board, POTS, and then the anxiety that comes with, having COVID should not be underestimated. Even if you become healthy, the stress of having gone through that is quite substantial. And there's probably more depression that we're seeing in post-COVID than you would see in ME/CFS. And then there are a host of GI problems, elevated temperature, flushing sweat. Some of these things, again, overlap with ME/CFS. So I think that's the main point that we should keep in mind when we talk about the value of going after COVID for ME/CFS. So just to say that ME/CFS is long suspected to be a post-viral illness in a significant percentage of those affected. So the NIH study enrolled people who had their symptoms beginning with what sounded like a viral illness, although nobody knew what the virus was at that time, and people tried to find the virus and haven't. But here we absolutely know what the virus is. COVID-19 has caused many millions of individuals to develop persistent symptoms that overlap with ME/CFS, as we talked about. And as they pass that 6-month period, they're going to meet the criteria for ME/CFS. So I was telling Oved that the pandemic is very sad, but it is actually a natural experiment to try and understand the post-viral condition that overlaps with ME/CFS, because we know the virus, we know the onset, and people with ME/CFS, the onset was sometime way in the back, and it's way too late to try and figure it out. And we can actually do the experiment where we can study the recovery process in those who have the virus and recover versus those who have the virus and don't recover. So we actually have a control group to compare, and that gives us the chance to identify what's different in those two groups that has then led to the cause of the persistent symptom. So that's the argument I would make for why this is so important. I just wanted to state before we go into the actual recovery study, the data on vaccination and long COVID. So the bad news is that having a vaccine does not prevent you from getting infected with COVID, although your infection, if you should get infected, which is much less common if you're vaccinated, and your infection is going to be less severe than if you were not vaccinated. But from the Israeli study, even in those who are vaccinated who got COVID, 19% have some symptoms remaining at 6 weeks. We still don't know out 6 months. That's not a lot different from what the CDC found with COVID in unvaccinated people. But there's another study that's a little bit better from Great Britain, showing that the risk of still having symptoms 4 weeks after a COVID infection is decreased by half if you're vaccinated as compared to unvaccinated. So I think we can make a good argument for vaccination because it's going to actually decrease the number of people with persistent symptoms by at least 50%, maybe even more. So another good reason to get vaccinated. There's also these unusual reports that people who have persistent symptoms after COVID and they get vaccinated, that they actually improve. Now, there have been a couple of studies, and it's not really clear what the real answer is here. It doesn't look like there's any downside to getting vaccinated. Some people do claim they improve. Sometimes it doesn't last very long. Sometimes it lasts a long time. Something really that we need to study in terms of the treatment of long COVID symptoms. So we know very little right now. We're in a very similar spot with long COVID as we are with ME/CFS. So we don't have a treatment. It's basically, good medical management. You need good doctors, just like you do for ME/CFS folks, good doctors to listen to the patient, have empathy, make a list of the symptoms, and then try to attack symptom by symptom to help the patient through this illness. And of course, there's a lot of anxiety because we don't know how long the illness is going to last. But that's kind of where we are. So treating people with post-COVID syndrome is really almost identical to the treatment that you would want if you have ME/CFS. Now, the silver lining now is that, as we know, in ME/CFS, it's been hard to find doctors who can do that. But with millions of people with post-COVID, there's going to be a lot more experience, and people are going to feel much more comfortable, I think, taking care of ME/CFS because of this great volume of people with post-COVID. There are some guidelines that came out of the United Kingdom. They're mostly, the kind of things that you see here. Now, there are a couple of things that are rising to the top in terms of speculation about what's causing the trouble. I'd like to say that we did know, and everybody knew, that people who went into the intensive care unit with acute respiratory distress syndrome, they have a lot of tissue injury, and we know that it takes them a very long time to recover. Actually, at a year, 75% of them are still impaired. And the symptoms are very similar to ME/CFS post-COVID symptoms. Fatigue is gigantic in this group. So we knew that was going to happen. The big surprise was that people who were never even hospitalized were also developing symptoms. So the initial clinics to take care of folks with COVID were basically set up to take care of people who were discharged from the intensive care unit. But what happened was those clinics became completely overloaded by people who were never even in the hospital, but still having symptoms after their COVID. So if you're in the intensive care unit, your probability of developing these long-lasting symptoms is extremely high. But if you look at all the numbers of people who were infected, since most of them were never in the hospital, the percentage of people with post-COVID is going to be predominantly people who have never been in the hospital. So one area that we need to really get at right away is to understand if there's persistent virus in the body that leads to ongoing inflammatory condition. So that's a top contender. There are some reports of virus still, or viral products still in the gut, in the GI tract, on biopsies of the GI tract. There's another report that I just saw recently on continued virus in the nasal mucosa when you biopsy the nasal mucosa. And so, as in ME/CFS, we started off by really going after what's the virus that's causing ME/CFS, and we didn't find it. Here we have to get at that question though: is there still persistent virus months after people have acute infection that is then still kind of smoldering, stimulating the immune system and causing trouble? And for that, as we'll talk about, you really need to get the tissue under the microscope. The next big one is the question of alteration in the immune system, because we know that COVID really changes your immune system to fight the infection. And actually, in fact, in COVID, the immune system gets overactivated and can actually be the cause of your eventual demise that gets super activated. So one question is that, abnormal activation something that was triggered by the infection and just isn't going away? So there's a recent study I just saw, it's not yet published, saying that there's basically these chemicals that the inflammatory cells make, that there's a certain set of them that are more common in people who have long COVID symptoms than those who recovered. So we don't know, that's just one report, but both of these things are testable, and there are potential treatment implications of both. One would be to alter the immune system, to counteract the superactivation. The other one would be to use antivirals to get rid of the virus. And then also we know when the immune system has been activated, many people will develop what's called an autoimmune disorder, because the immune system, it's activated against the virus, but it's so activated, it starts to attack our body's own self. And that's what autoimmunity is, when the immune system turns on the body. And that happens when the immune system gets really jacked up after an infection. So Guillain-Barré is a great example where that happens not uncommonly after a viral infection, because you get autoimmunity against the nerves in your body. And some people think that, and there's some evidence that that may also happen in postural orthostatic tachycardia syndrome, which is, as you see here, we all know it's so common in ME/CFS, but here you can see it's also very common in people with COVID. So what is the recovery? The recovery, because we did get $1.15 billion, as Oved mentioned, we really put together something that is, it's got a lot of ammunition in it. We're not fighting this problem with sticks and stones. We're fighting this with real heavy ammunition. But to start, we basically went around, and I and Amy Patterson from NHLBI, a couple of other folks, we were on the phone a couple of times a week talking to patients, talking to doctors who take care of people with post-COVID, and we learned quite a bit. There was a video workshop with many people from the ME/CFS investigator community spoke and talked to us about post-COVID. And then we developed this program. And the goal is to understand and then predict, treat, and prevent post-acute sequelae of COVID. And by post-acute sequelae of COVID, we mean a couple of things. The obvious one to people listening is probably the long COVID syndrome, the syndrome that resembles ME/CFS. But in fact, the other thing we have to worry about as a health organization is what's the long-term effects of COVID. So post-acute sequelae means we have to know, if you had COVID, does that affect your chances of having a heart attack or a stroke or dementia 5, 10, 15 years from now? We have to set up to study that. That's also part of the post-acute sequelae. But of course, the focus is heavily now on the acute part of it, the long COVID syndrome. So we want to understand the biology underlying recovery, normal people, what goes wrong if people don't recover, understand the risk factors, the incidence, the prevalence, and then the subphenotypes, or different subtypes. There are over 70 different symptoms been reported in people who have persistent symptoms after COVID. Some of them cluster. You may have, I think the average is like 13 symptoms. So everybody doesn't have all 70. So there's little clusters, and we have to figure out what is different. Are they different disorders, or just different manifestations of the same disorder? Now we need to know what happens over time and its relation to organ dysfunction. So in acute COVID, we know, for instance, that your lung is infected. One of the potential complications of a lung infection, viral infection, is what's called pulmonary fibrosis, or scarring of the lung. So we have to actually follow the injury pattern to know how the body's recovering. I mean, pretty much all the organs in the body are vulnerable. They all have been hit during COVID, and what happens long-term to the pancreas, to the brain, to the heart, to any organ is something that we have to really pay attention to. But the key thing is we want to learn enough that we can then make interventions. So because it's so many different organs, this is very multidisciplinary. So we got, general practitioners, we got cardiologists, we got neurologists, we got a lot of immunologists, dermatologists, pediatricians, very multidisciplinary. We're trying to be very inclusive and have a diverse community in our cohorts. And we know that we don't know the answer. And so we need to be very flexible and adaptive and move as the science moves. So the idea is, here is the beginning of what we're doing, is to set up what we call a meta cohort, which is basically 30 highly meritorious clinical cohorts of people, some of whom are normal but had COVID, some of them had COVID and are still having trouble, some of them are acutely infected, and we want to see how they recover. There's hundreds of sites across the country. We'd like to get some answers quick. So we're shooting for 12 months, and the first patients got enrolled 2 weeks ago. So we're really gearing up now. And we're looking at adults, including women who were infected during their pregnancy, what happened to their children. We're looking at children, and then I'll talk about, we're really focused on getting autopsy material from people who died for whatever reason, but have had COVID, so we can answer some of those questions that I mentioned before. Is there virus still in the body hiding somewhere? And so we call these the recovery cohort studies, with living people being enrolled, and they're doing this on altruistic basis. We'll have autopsy studies. And then we also have what we call electronic health record studies, where we can look at data from medical records, not in 10,000 or 15,000, but in 42 million people over time. So we're enrolling the cohorts now. They're collecting clinical data, radiology imaging data, cardiac echo data, mobile and digital health data. We're going to working to work digital apps that people can wear or use to input information, the medical record. And we're also going to bring the pathology data from these autopsy-based studies together, all this going into a data core, all the information going to data core. And we'll also bring samples, tissue samples, blood samples, whatever, into a biorepository core, so that people around the country, maybe even around the world, can test their ideas on samples that have been collected during this process. So as I mentioned, we want to have an acute infection cohort, people who are infected now, so we can watch how they recover. And the percentage of those who go on to post-acute sequelae of COVID, it could be 10, 15%, depending on how you design it. Certainly it's going to be higher in people who are hospitalized. But that gives us a chance to look at the recovery period and see what went wrong in the people who don't recover. And then we'll have people who are now, weeks, months out past their infection and still have symptoms. And we'll have a control group that is weeks or months out, the same amount of time, matched to the people who have symptoms, but those are the control people who don't have symptoms. So we can say what's different about those who recovered versus those who didn't. And we're talking about 200 sites, 50 states. And the main thing is we have an army of people working on this. And I think that is also important to know, because, certainly in MECFS, we haven't been able to get an army together. So the agenda that I have, and you have too, hopefully, is that we can turn this army on MECFS at some point as well. Because they'll be very experienced in the problems we're working on, even unrelated to COVID, MECFS. So these are the kind of data that we're going to be collecting, electronic surveys, paper surveys, lab results, electronic health record data, huge troves of data bring into data centers, but it's brought in a very kind of standardized manner, so everything's harmonized. So someone can go in and say, I want to see all the people with X, Y, and Z, and every site, you'll be able to see from every site who had X, Y, and Z, as opposed to A, B, C, and X, Y, and Z, and apples and oranges. So the data, hopefully a lot of the standardization that went into this will make the data and the biosamples much more valuable. We have, and I'll talk about this, the idea is to come in all the patients get what's called tier 1 screening. So these are kind of this is an old list, it's not updated. The group is still working, they're testing the procedures that they're going to be using, and they're still changing them. They're in what's called a beta phase, but when they're done with that, they will publish what their protocols are. But the screening are things that are going to be done on everybody, and they're all done in a standard fashion with what's called common data elements. And then depending on what the screening shows, they may go into a little more intensive testing. That's called tier 2 testing. And then a certain group, say, for instance, you find somebody who has post-exertion malaise, or they would go and potentially get a cardiac echo. If their cardiac echo is abnormal, they might go on to an MRI of the heart. So the idea here being there's something that everybody gets, that's tier 1. Tier 2 is based on the symptoms, and then tier 3 is really in depth. We'll also be funding studies of people who have ideas that are kind of very much important, but may not have been thought about in this tiered testing. Add on data and do kind of extensive. You might have somebody who wants to do, cerebral spinal fluid studies in people with cognitive trouble. That could happen through this. Tier 3 does have spinal fluid, but someone could start off right away by doing a big spinal fluid study as well. So this just shows the numbers that we're looking for. And so these are massive numbers, 9,000 in tier 1, 1,800 in tier 2 for the adult. And then there's similar numbers for the pediatric. And then the autopsy, again, these are high numbers to try and get autopsies on 700 people who are COVID positive. But unfortunately, the truth of the matter is that there are millions of people COVID positive. So anyone who's dying in this current period of time, high likelihood that they had COVID. And then the autopsy procedures are here. So again, it's all very standardized so that, 50 anatomic sites. So I think, what we get from one site, we can compare it to another site. Certainly a big problem with MECFS is that, we have work coming out of one site and no one has really reproduced it in the other site. But here with Recover, we're going to be able to build that in from the beginning. And this is just to scare you. This is the diagram of where the data goes. And the only thing to mention is that there'll be one place, the researcher will just go one place and he'll be able to tap into our workspace. And then without him, doing anything, he'll be directed to all the different repositories for the different types of data, whether it's pathology or electronic health record or the clinical data. And then I want to mention right away that the goal is to learn something quickly that we can then go into clinical trials to test, because we really want to get as early as possible studies going to see if we can help the symptoms. The longer they go on, the harder they're going to be to treat. So we think that's also a big part of this, but we need some place to start. Now, these are the places that have been funded to do the work, but these are just the big, coordinating centers. RTI is a company, NYU, New York University, Mass General for the data. All the repository samples go to Mayo Clinic. These are the cohorts, autopsy, electronic health record, and the cohort are here, all feeding in to this data center. These are the places, these are the centers that are now developing the cohorts, but these are just the centers. So one hospital mentioned here might have 5 other universities associated with it. So these are kind of the hubs, and they all have spokes. And then there's pediatrics as well, pregnant population, the tissue pathologies, the autopsy studies, and then the electronic health record data. So all these have been set up and they're gearing up to go. And, we're talking about, big numbers here, and hopefully this will help us to get answers. Certainly the kind of numbers and the organization we've never been able to get together for ME/CFS. We can do that for COVID. And the lessons learned, I think, as I mentioned, I think have a large chance of helping us understand ME/CFS. And, if there's a treatment in the COVID space, the first thing we're going to try and do is see if it makes any sense to try in a certain group of people with ME/CFS. So that's, I think, the main things I wanted to say. We have websites up for people to see what's going on and recover as time goes on. And I want to thank you for your attention. Happy to answer any questions.
Thank you so much, Dr. Koroshetz. That was very, very helpful to really see the scope. And I think, as you said, a very, very ambitious study. We have received a number of questions from our community before the webinar. So I'll start with those, and hopefully we'll have time for more. But I think sure. the first question actually comes from a person who, as I understand, contracted COVID-19 a year ago. Has since been diagnosed with ME/CFS. And the question is, you've shown us that there are going to be a lot of people involved in the RECOVER study. How will you ensure that researchers that are funded by the RECOVER project are actually familiar with and build upon existing ME/CFS research?
Right. Well, a really good question. As I mentioned, when we were starting this up, and certainly as I knew from ME/CFS, that the symptoms, the condition we're dealing with, is closest thing is to ME/CFS. We reached out to people like Tony Komaroff and others who work in ME/CFS to be part of the listening sessions, informational sessions. The RECOVER project has lots of different people in it. I don't know everybody who's in it, but for one example, the Bateman Horn Center for ME/CFS, it is a member of the Utah group that's now bringing in patients, and I think ME/CFS clinicians have been invited to participate in the oversight committee looking over the whole project. And I think there's probably, they're probably peppered into the hundreds of investigators that have gotten together. And then the truth of the matter is, I think that, with ME/CFS, our problem is we never had the numbers. And so if we can, get, some of the hundreds of people now coming into RECOVER, to start working on ME/CFS, then that's another, benefit that comes out of this for us.
So maybe to add to that question, do you think that there is a possibility to add into the study design and as it unfolds, to perhaps find ways to educate many of those clinicians who perhaps, from our previous experience, we know have not been involved in ME/CFS? Is there a way for us to do it more in a more structured way? And maybe there is a role for us as the organizations and community that are involved. Is there a way for us to be part of that?
Yeah, well, I think, that's a great idea. I think, they're going to be working with people who have ME/CFS-like symptoms, and they're going to be challenged. And so I think you're right that a chance to educate them is probably a good idea. Right now, they're busy, just going through all the paperwork. But I think that's something that we should be doing down the road. As we have the community and they start working, to have these kind of workshops and meetings, and where they can share information and to bring in people experienced in caring for people with ME/CFS. I think that's a good idea.
Wonderful. So then we'll definitely follow up on that later on. We understand that there's a lot of work involved in the setup, and but we want to make sure that this is part of the plan. The next question, I guess, is related, and the question is, how are the existing researchers that are funded by NIH, specifically related to ME/CFS? I guess the question is related to the Centers of Excellence that are funded by NIH. How are they involved in the RECOVER initiative?
Ooh. Let me see. I'll go back to my chart and see. I did, not sure if there's an overlap. Well, let's see. Is the Bateman Horn part of the consortium? Can't remember.
No, but there's a lot of expertise there for sure. Yeah.
Yeah.
So that's, I think the question really is highlighting for us that there's a significant amount of activity already within the NIH, and we would like to make sure that there is a connection and use those as a way to advance the objectives of the RECOVER study.
Right. Yeah, I mean, there's so many, there's hundreds of people involved. I'm not sure who's who, but
so that there's obviously an opportunity for us to continue to strengthen the that connection, and really to make sure that the community is contributing from our prior work, contributing to the RECOVER effort.
Yeah.
There is the next study is related to biomarkers. And obviously, you mentioned how in the past it was so difficult to identify specific biomarkers that would be potentially used not only for diagnosis but also for prognosis and understand disease trajectory. Is there a component of the RECOVER study that will be focused on the development or investigation of such biomarkers? And I would probably use that in plural. It's probably not a single molecule, but you mentioned the idea of an immune profile, for instance. So is that something that is part of the goals of the RECOVER project?
Yeah, I know. I'd say that the immune profiling is probably at the top of the list. That's what people are thinking is, potentially the most likely culprit here, that you're having persistent immune activation, whether it's due to leftover from the acute infection or whether it's due to persistent viral products in the body. So I would say, that's probably the low-hanging fruit that people are going after. And there's already been work that's, is casting suspicion on that is the problem. And in ME/CFS, we've definitely looked at that. There might be some nibbles, but it's not that clear yet. But in ME/CFS, it'd be difficult because you're looking at people years later. There'd be much more heterogeneity. You could miss the real important immune abnormality that you'd have a chance to get now in the post-COVID patients. And maybe in the ME/CFS patients, you could have gotten it, 8 years ago when they first got it. We are doing a similar study in Chicago where we're looking at ME/CFS and people who had Epstein-Barr virus causing infectious mononucleosis. I mean, that's a study in college kids where mononucleosis is not uncommon, but you don't get the numbers that you can get in COVID. So, but it'd be interesting to see if there's any parallels there, for sure.
Yeah, I think that would be very important, obviously, to continue to look for those connections. So the next question is related to something you touched upon, which is that it seems as if the first phase is not looking specifically at the interventions or treatments, but it's really gearing up towards having the enough understanding on how to do that. So in your mind, what is the expectation? What is the timeline for this kind of evidence-based treatment options? What is your expectation for when would that be the next part of the study?
Well, I think that what you'd like to do when you develop this kind of infrastructure, what you'd like to do as soon as something looks like it's promising, that you just tap in to your infrastructure to do the trial. So they'll have thousands of people recruited into their study. So if we needed to do a trial, say but it depends on what we find. Say, for instance, we see there's persistent virus in the body and there's evidence of viral replication. Well, I would say the first thing you want to do is to test an antiviral agent. And there's two of those. One, I think, just got approved in Europe, but there's two of them that look pretty promising for approval in the US. So I would say that, if that makes sense, that there's virus replication and the mechanism of replication is relevant to the action of these two drugs, that's what you would want to try first. Now, if you look in, there's no virus, then there's no sense using an antiviral agent. But that the other thing that that I reports of people getting better after vaccination, that could be non-specific, that it affects your immune system somehow, and so your symptoms go down, or it could be that your immune system gets revved up and clears some more virus, and then you're out of the woods. So I think that if you're looking for a real lucky strike, that might be the one that would be out there. Now, on the other hand, that's not that helpful for people with ME/CFS because the treatment is COVID specific. If it's an immune abnormality, then it might be across the board, ME/CFS and post-COVID. So if you find an immune abnormality, then there are drugs that you can use. For instance, if cytokines are the problem, there are now monoclonal antibodies against cytokines that are used heavily in cancer, for instance, or immune diseases that you could then, rationally test in post-COVID. And then, if you see something like that, then you go into your ME/CFS community and see, is there a subset of people who have that same cytokine elevation that would potentially respond to treatment? So I think logically that's the way it would go. Now the other thing to say is that in medicine, you can be as logical as you want, but sometimes, you just got to keep your eyes open. So with all these people being treated in all different ways, I mean, we have to know, keep our ears open. If some of the patients and docs are saying, oh, guess what? This seems to be working, forget whether it makes rational sense. You got to go test it in the population. So
yeah, that was going to be exactly my question. So is there an oversight committee, or is there a way to and so that in that committee potentially
it's called an Oversight Management Board. It's called Oversight Management Board. So they're looking over the trial, and everything that gets done goes through them. And then it comes to NIH. So there's another board, which is the Executive Committee for Recover. It's made up of institute directors. Dr. Gibbons and I are the co-leads of that committee. But yeah, so if anybody finds anything, tell me. I'll be able to, kind of broach the subject. But I suspect that the OSMB people are, they're really on top of things too. So there's multiple different ways, and the investigators themselves are going to be seeing things. So like lots of avenues for what you'd call, epiphanies to show up in this system.
And just to clarify, those epiphanies will be supported by budget from
from Recover, right?
Yeah. Okay. So that's
we're trying to hold back money for studies that that come on, either to plug into Recover or maybe standalone studies, and as well as money for trials.
That's very important for us, I think, to know that. And I think you already mentioned that there will be potentially, or there will be money for funding for other ideas that come out that are not part of the initial study design. Did I understand that correctly? Okay.
Yes.
So we only have a few more minutes left. The next question that came from the audience was, is there a DNA database, whether for ME/CFS or long COVID, and is that part of the recovery design? And if not, is that something that you are contemplating on adding in the future?
Right. So there will be collection of DNA, and I think that it could be that a widespread analysis of the DNA and recover may be necessary if, you think that there's certain genetic vulnerabilities that lead some people to post-acute COVID and not others. So yes, now in ME/CFS, I think that there are, collections around, but nothing on the scale that Recover is going to have, as far as I know. I mean, I could be mistaken.
And that is part of the initial phase of Recover, so that the DNA is going to be
collected. Yes. Well, I don't know that I must say I don't know specifically whether we, plan to do when we plan to do the analysis, but I can imagine that that's definitely something we're going to have to do. But I can't recall whether it's ongoing or whether we have to get a certain number of patients or when that would occur. But the good news is that it's cheaper to do now than it was a couple of years ago.
Yeah, and that obviously would be very important to look at as we get more information. There were just a couple of I thought very important questions that came in during our conversation. So I'm just looking at that, and maybe one that you may be able to address now, which is we were not, as the patient community, we're not aware of any patient engagement at the oversight level. And do you feel that there's a room for that involvement?
There are patients, I think.
There are patients who are involved.
There are patients who are on the oversight board.
Okay.
I don't know particularly who they are, but that was the plan, yes. And I think that there's also going to be patients involved at all of the sites and have been involved in designing and kind of the beta testing of the protocols.
So that's something that we would obviously be very interested to learn more about. We know that there was some involvement in the protocol design. This was not probably, from what we hear, the best engagement. But it will be fantastic to understand how at the site level patients could be involved. We know that patients were the first to describe long COVID in a way that was extremely helpful. So we want to continue to see that.
I'll get back to you. I think I could get back to you on the mechanism that they're using to reach out to patients. But I think that was designed in early on, and it's important to continue with. Yeah.
So we're obviously we're here, and we want to continue to be a resource for that. Maybe one more question that came during the conversation. Is there a plan to test some of the therapies that were already used in the ME/CFS community? Obviously, with not a lot of well-controlled studies, but treatments that benefit some people with ME/CFS. Is there a way to test that with long COVID?
Well, I think the issue and what to test, it's going to depend on what the package looks like in terms of the rationale. And I'd be happy to be wrong. I just don't know. I just don't know what effective treatments there are for ME/CFS. I know that certain people have tried different things and people have responded, but it's very difficult to know what the drug did and whether it actually drove the response. Because you do need a clinical trial for that due to all the variability. So I'm more helpful that something from COVID will then be able to be tested in people with ME/CFS than I am the other way around, unfortunately. It's sad to say that, but I think that's the way we are.
Yeah, we'll be we'll be watching that obviously very with a lot of anticipation. So, Dr. Koroshetz, I think we're just about at the end of our time. This was such a pleasure to have you with us. We would like to invite you again, maybe before not too long, to learn more about the study rollout, and more importantly, how can we continue to support and help continue to bridge the existing knowledge within the community with the recover effort. And we would welcome the opportunity to be involved in any patient engagement activities that are part of that. And I think we've also generated some ideas about education, other ways for all of us to continue to be involved. So we would very welcome the opportunity to continue to advance that.
Yeah. Well, I want to thank you for your help getting this off, but also, people who are developing these symptoms after COVID, none of this gets done without you in the studies. So we talked a lot about what the NIH is doing, but it's actually the patients who are enrolled in the study that are doing all the work. So hats off to them, and anything that you can do to spread that message would be appreciated.
That's what we're here for. Well, thank you very much, Dr. Koroshetz. And I'll let Jesse conclude the webinar today. And thank you very much, all of you, for joining us.
Absolutely. Thank you both so much for this really interesting conversation. And thank you, everyone who added questions in the Q&A box. We will definitely follow up with those questions after the webinar. And you can find this recording on our YouTube channel a few days afterwards, youtube.com, and then search for the Solve CFS initiative. And right here is some more information about future webinars, information about ME/CFS, information about how to get involved with Solve ME. And again, thank you for joining us today, and take care. Bye-bye.
I know.